What's up, everybody? It's Dr. David here from El Paso Manual Physical Therapy. We're going to be talking about the top 10 questions everyone has about healing knee osteoarthritis today. So if you got knee arthritis, if you've been told you have a bone-on-bone arthritis, if it's stiff, if it's painful, if it gets swollen, if it's keeping you up at night, if you can't walk, if you can't exercise because of it, I'm going to answer a lot of the questions surrounding knee arthritis today. So thank you guys for joining us live here. We're live on Instagram, on Facebook, on YouTube. I can see comments right here. My team's feeding me some comments. But I want to let you guys know, let me know where you're from. Comment what part of the world you're in, what city, what country, what state, all that stuff. I'd love to hear where you guys are from. It's always such a great thing to see. There's Cindy already. She's here from Odessa, Texas. I love it. Cindy is always here. Julie is always here from Australia, from Sydney. Thanks for joining us, Julie and Cindy. And then we have a quick question here. How do you heal your knees with and without arthritis? One of my knees randomly gives out while I'm walking or jogging upstairs. What are your suggestions? Oh, there's so much. That is a loaded question, Mr. Moore, Mrs. Moore. I will be talking about that today. So we'll get into that. Stay tuned. We'll talk about these questions here. We have EV from San Diego, California. So cool. The border town. We're in El Paso. We're in a border town, El Paso, Texas. We have Mina in Toronto, Canada. Awesome. Who else is here? Chronicles, North Coast, Cali. Oh, so cool. We're in California, beautiful part of the country. Thanks for joining us. Kimberly, she says, hi, Dr. David and EPMPT. Everybody's waving at you from behind the scenes, Kimberly, and they're all doing hearts to you, Kimberly, because you're like one of the OGs from our lives here. Julie Parker's always here too. We have Cindy always here too. Mina's always here too, and with questions, she says, hello, Dr. David, I have two questions. One's related to foot pronation inwards, and the other one is related to extreme pain in those two quad heads just above the kneecap. Please guide. Do you want me to keep going? She's got other questions. Whenever I squeeze my glutes in the standing position, I also feel a bit in my quads and hamstrings, but I don't feel them that much during sitting or lying down. Is that possible? What am I doing wrong? Well, to answer your questions real quick, it's usually just a rest thing. So you feel them in one position like standing or sitting, but you can't feel them in another position like lying down. It's a matter of getting the nerves connected to the muscles, which is usually just reps. There's no magic trick. There's no like special exercise that I'm keeping from you guys or technique or like a pill or a shot that you can take for that. That is just reps. I mean, that is, think about when you were learning to handwrite and you were learning to write the letter A, the letter B, the letter C, and so forth. Your first A looked, let me just try, because I'm sure my first A looked terrible like that, didn't look like an A, and then as you get better at it, you start to make a prettier looking A, and then some of y'all get real fancy and make this kind of A. And so it's great. You see how fast I did it, but when you need a lot of thought to do it, it looks very nice, and so you just have to practice it. I'll get to the other questions as we keep going along here. So I hope that helps you out with the good question. I'm going to switch mics here. Thank you. I'm so thankful for my team, the technical difficulties. By the way, there's so many things that you guys don't even know happen in the background. And thankfully, we can keep the show going here, keep the live stream going, thanks to the team. So clapping hands to you guys. We have P. Moore in Michigan. Fantastic. What else is here? Cindy says, I learned so much every live show or video. Right? That's my goal, is for you guys to learn and apply this stuff so that you can get the outcome that you're looking for. Hopefully, avoiding surgery and getting back to doing what you love. Alex is in Germany. Fantastic. And Europe checking in. Hi, Dr. David from Alberta, Canada. That's the guy. I'll just say the guy. It's a long username. Canada's here. So cool. We have another Canadian from Oakville, Ontario. That's Kim here. Fantastic. Mina says, do you have a center where I can come for rehab? Yes, we do. Here in El Paso, Texas, we have a clinic in our office. We have both, a whole online setup here in our companies. We have a stage like this. We have a couple stages actually. We have, our staff that does the video online side of things. But then we also have a full-fledged clinic that you can come visit. So we love having people come in. Half our schedule is people from out of town. So it's a normal thing for us these days to have people coming in from all over the world. We have people coming in from all over the U.S., but even outside the U.S., Canada, Indians visit us frequently as well. What else is here? We got. Let's see. Oh, Joe says any tips on rehab after quadricep tendon reattachment operation? Yeah, I can give you some really quick, easy tips, Joe. Number one is be patient. It takes a while, and even though the job, right, your tendons healed, I don't need to anymore. There's still patience to be had afterwards because you can't just get back to full speed. Running, jogging, exercising. Depending on how active you are, you have just got to be very gradual with getting back to activities. Even after, because by the time the doctors release you, you have to realize that healing in tendons, especially, it kind of happens like this. Like if I draw a graph, draw a little bit bigger, you do a lot of healing and then it kind of plateaus, but it still goes up near the end. And usually the doctors are discharging you at about right here. And so you're, maybe 70% healed. You're good enough. And the remaining 30% is on you, but that takes a lot longer. And healthcare isn't designed to be seeing you that entire time because this whole process here might have been, 2 to 3 months, and you still need another 6+ months. It might take you the better part of a year. That's what I typically see to get back to like full speed, doing everything that you were before. I mean, if you think of ACL surgeries or knee replacements, as we're trying to avoid here through the teachings in this video, 2 to 3 months is what you're seeing the doctor for very often. And the doctor's like, all right, you're good. 3 months, your PT's done. Same thing with the patellar tendon tear, the rupture in the surgery afterwards. It's not always that the doctor is done, because I don't think every doctor out there would say you're 100% done. I think they'll agree you're about 70-ish% done. It's just that insurance-wise, healthcare, payment-wise, they tend to cut things off right here and leave you on your own afterwards. And that just isn't always, it's not always explained to people that you still have some work to do. So you have to understand that. So be patient. That's number one. Then number two is stay active. If you don't get active again, you won't strengthen the tendon. Keep in mind, the tendon responds like the muscle. It's a force transmitting tissue. In other words, it transmits the force from the muscle to the bone. And so it needs tension going through it gradually to increase over time. So just be patient with it and keep exercising. The worst thing you could do is not exercise. You're going to weaken that tendon. All right, we have somebody from Fiji. Oh, it's one of my bucket list destinations I want to visit someday. So jealous that you're there right now. Parveen, it looks like. When you coming this side? Oh, I would love to be there right now. One day, that'll be fun. So cool. All right, guys, let's get to this lesson. So top 10 questions everyone has. Let me give this a proper introduction. We're covering today the top 10 questions that everyone has about healing knee arthritis. So these are questions that I have pulled from our comments in YouTube, from chatting with AI, from my knowledge of talking to patients. I think you guys are going to feel that you have a lot of these questions, or maybe you haven't directly consciously asked this question to your doctor or somebody, but when I write it out or when I explain it to you, you're going to be like, oh yeah, I do wonder about that. So the number one question that I get when it comes to healing arthritis is, can cartilage regrow? Is it possible for cartilage to grow back? There's kind of different versions of this question. If I have lost, where's my knee? I'm missing the knee joint. Do you guys have it? If I have lost a bunch of cartilage, look at this model right here. Y'all see that? So this would be like a healthy knee joint. All the grayish bluish stuff right here is cartilage, and this is healthy, a normal knee. And then this is the extreme, stage 4 arthritis, bone on bone. And you can see all the red spots that have developed there. That's like lost cartilage. And if you open up I've done cadaver dissections. I'm sure surgeons are seeing this all the time when they look inside joints. The cartilage can look kind of damaged like that. And this is extreme, bear in mind. But you have smaller amounts of it. And in this model, it doesn't open up like the other one does. But there's a little bit of a loss right here. I think that's still a lot because I've seen people in practice, like in treating people that have bone-on-bone knee arthritis and have been told that they've lost cartilage, or at least they're thinking that. Maybe they didn't get told that. That's what they're communicating back to me. And they're asking if it can regrow. And there's all these treatments associated with regrowing cartilage, like stem cells and PRP injections. There's injections out there. And even exercises are thought of to possibly regrow cartilage. So let's answer this question. Here's my response. I don't know. I don't know if it's possible to regrow cartilage. No one really knows, actually. When you look at the science and the research out there, we don't have anything that solidly tells us, yes, if you do this or that, if you get this treatment or this combination of treatments, you will regrow cartilage. No one really knows. As it stands in the medical research, we haven't figured it out. From my perspective, me personally, this is my opinion, I think we are in the Stone Age when it comes to medical research. There's some things we figured out for sure. We've figured out the wheel, if you will. Like we know that for the one thing that I think we can solidly put our finger on is that if you are at a decent weight and you are decently physically active, you're probably going to be healthier than if you're not at a decent weight and you're not physically active. But that's it. That's the only thing that we really have solid information on. There's a bunch of other things that are kind of being studied. Some things we're gaining ground on, some things we're not. Now, I'm not trying to discount or throw under the bus that we haven't made some major medical breakthroughs, because I do have to say, with all complete respect, a knee replacement surgery is breakthrough. It is pretty incredible that surgeons have figured out that we can saw off the ends of the bones, and they have figured out how to make these medical parts and install them. And there's people walking around all over the place with a prosthetic inside their knee joint, and you may not even know unless you saw their scar or they told you. That is a medical breakthrough. However, the questions that I ask that make me say that we're in the Stone Age is, how do we even prevent getting there? How can we prevent the surgery altogether? And this is related to that. If we can get the cartilage to grow back, might we not need to have a knee replacement? But my answer, to fully give you the answer, is we don't know. Here's my belief, though. This is my belief, my opinion, okay? So take it with a grain of salt. You can go do research on your own. My best advice is to go try what I say and put it to the test on your body. There's little to nothing to lose except some time in trying this, and you're probably going to get better anyway. But my belief is that you probably cannot regrow lost cartilage. That's my belief. Now, let me break this down. Don't stop there, okay? You need to hear my full explanation to understand this. The assumption that you have lost cartilage is given to patients all the time based on an X-ray. X-rays cannot see cartilage. You have to have an MRI or surgical visualization. You have to have somebody do surgery on your knee to see that the cartilage was actually gone or dead. And that's risky. We don't want to do that if we can avoid it. So the X-ray is the main thing that healthcare professionals out there are using to tell the patients that they have lost cartilage. And what I think doctors should actually be saying, I don't know what they're literally saying to patients, I just get it secondhand from the patients. What the patients are telling me is, my doctor said that my knee is bone on bone and the cartilage is gone because the bones are touching. But what you have to think about is, in my treatment approach, with the muscle imbalances, meaning the quad muscles usually are way too strong, they're over dominant. In case you've never heard this, I want you to understand this. In your knee joint, here's the kneecap,
and the quad muscles all attached to the kneecap. When those muscles are over dominant and very strong, which is what I think happens in 99.9% of people that have knee arthritis, those muscles are yanking up too intensely and too consistently, and they're pulling the kneecap forcefully against the thigh bone, smashing the cartilage there behind the kneecap and on the thigh bone. And then because of this attachment down here, it continues onto the shin bone. It's pulling the shin bone up into the thigh bone. So everything's just being smashed because of muscle imbalances. And in the x-ray that looks bone on bone and cartilage is gone, what you're looking at is a smashed knee joint. And because cartilage is squishy, it's firm, but it has some give to it, that cartilage looks smashed on the x-ray, not gone. That's an important distinction, because if you can unsmash it, if you can take pressure off the joint, there's a chance you could be just fine and heal. And then whether or not cartilage can regrow is kind of irrelevant. Doesn't really even matter. Now let's look at the flip side of this. In this same model that I just described, quads are too strong, smashing your joint together, and your poor cartilage joint looks like it's smashed like this on your x-ray. If you were, let's assume that you got stem cells or you got a PRP injection, you got some magic injection or some magic treatment that did regrow your cartilage, but you never fixed the muscle imbalance and it continues to be smashed. Well, guess what? You're going to smash your brand new cartilage cells and probably kill them, destroy them, whatever. It's going to look like this eventually, no matter what, because you haven't fixed the muscle imbalance. So when you ask the question, can I regrow cartilage in my knee? I think you're asking the wrong question. And don't feel bad, because you asked that question as a result of the doctor saying your cartilage is gone, but their thinking is faulty in my opinion, because they're just looking at the x-ray and they're assuming, they don't know for sure. They're assuming that you've lost cartilage because your thigh bone and your shin bone are touching too much, or they're too close together. And so therefore, in their heads, you have a reduction in your cartilage. You have a reduction in joint space. Where your meniscus is, they're thinking your meniscus is gone. And it's you've lost cartilage there, is what they end up saying. And so those words then stick in your mind because your knee hurts. And you're there in the doctor's office looking at these x-ray images, freaking out because of what you see. You may not even understand it all. And in reality, I get MRI reports all the time. And I look at it and it's like mild to moderate. And I'm thinking to myself, this person's going to heal excellently if we can take the pressure off the joint, which is a very doable thing if you go through the right treatment approach. So to answer your question, can cartilage regrow? My summary is we don't know, but it kind of doesn't matter. Just fix the imbalance and you're going to be just fine. Great. Answer that question. Let's go to number 2. Number 2, kind of related. I'm just going to summarize it here. Hope for bone on bone. Is there any hope for me if my knee is bone on bone? And so you just heard my explanation, hopefully, on the cartilage idea. And what I can tell you, to just take it a step further, we've taken polls. Over half the people in our knee arthritis recovery program were told that they have bone-on-bone knee arthritis. And our success rate is in the 90 percentile. Like, we are taking more and more measurements. As we get more people going through our program, we're getting more data. And we're able to see that over 9 out of 10 people fix their knee arthritis and they're avoiding a surgery, a knee replacement surgery. And over half of them, the last number I saw was 54%, were told that they have bone-on-bone knee arthritis. So when you ask, is there any hope for me if I have bone-on-bone knee arthritis? I can tell you, I think so. Most of the people in our program have been told they have bone-on-bone knee arthritis. And if we can decompress the joint by fixing the muscle imbalance, then you have an excellent shot at unsmashing your knee joint. I smash my face like this because the analogy I like to talk about is, if I were to take a picture of you with your face pressed up against the window, you wouldn't look like you normally do. But if we were to take your face away from the window, then you look like your normal self. And if that was the first picture that I ever saw of you with your face smashed up against the glass, I wouldn't have an accurate picture of what you look like. And oftentimes, one of the first x-rays or the first x-ray you've had in a long time of your knee joint looks with like the bones are touching, and then the doctor's thinking, oh, there's a loss of cartilage because that's what they told me to look for in school. And that's what my mentors told me. And I've seen people have knee pain that they've made correlations in their head, but they don't know about this treatment approach that I'm talking about where you offload the knee joint and fix the muscle imbalances. So they're telling you, yeah, there's no hope. It's eventually, it's an inevitability that you're going to have a knee replacement one day because your knee looks like it's bone on bone, and there's damage. There's a bone spurs, and there's potential damage here, and you had a meniscus tear already. They start to kind of line up all the factors, build the case, and then they'll connect it to you. And you know what they end up telling you? Usually they'll say, when your pain is bad enough, let's go ahead and do the procedure. Let's do the knee replacement. And they leave it up to you very often because it is an elective procedure. Because the reason why it's an elective procedure is because it is possible for you to look terrible on your x-ray, severe osteoarthritis, but feel fine. And that you wouldn't do surgery. So that's why it's an elective procedure. It's based on how much, on when you want to do it, if you feel like you need it. Hey guys, I want to let you know that we have a helpline. While we're on the live stream right now, if you're watching this live, our helpline number is right here. I am available to answer your questions here live on our live stream right now. The number is 915-200-4159. Once again, it's 915-200-4159. Call us up. I'd love to answer any questions. I'd love to get you unstuck. If you're worried about, if you have another question to add to our list, I'd love to answer it. I want to make sure that you get help today. We're good to keep going here? All right, let's go to number 3 here. Oh, I love this one. I get this one all the time. Too late. When is it too late to have a knee replacement surgery? And the way this question's asked is it's asked with the point of reference of my doctor told me that I have a window of time to have surgery in. Like I want to make sure that it's not too late. And sometimes it's age related. They'll say, well, once you're over 75 or 70 or 80, I hear different numbers out there, then the window of time to successfully do a knee replacement is gone, and the doctor's going to tell me I can't do it anymore. This whole window of time thing is, what you have to realize is that it's subjective. In other words, doctor to doctor, it's different. And what I think it has to do with is what that doctor independently has decided that they're okay with doing based on their skill level, on the history of patients they've seen, on the demographic of people around them, like the overall health and fitness of the people. Because what it really is dependent on, it's not age, it's your physical condition. Because what the doctor's actually thinking about is, based on the health of this person right now, whether they're 50 or 80, can they endure the anesthesia, the medications that you're going to get, the very strong medications you're going to get, because it can cause some heart problems, it can cause some other issues. Can you endure the actual surgery itself? Like, we are going to cut out parts of your body and have your knee flapped open for a while we do what we have to do, and then we're going to install new parts in there, and you might have some reactions, you might have some getting used to it. Can you physically endure that? And then comes the rehabilitation afterwards. You are signing up for months of physical therapy and just dealing with a brand new knee, which takes some time to adjust to. And a lot of people do it successfully. I do have to say that knee replacement surgeries are better than ever, but they still have problems. And it's probably desirable for a lot of you guys to just avoid it altogether rather than moving into it with risk. Like, you have to be kind of desperate to move into it. And of course, you've tried everything, but have you really tried our approach? Have you done it correctly? Because there's some finagling it and customization that might need to happen for you. That's why we have the knee arthritis recovery program, to make sure you get through it. But the whole window idea, the window of time, and when is it too late? It's dependent on you. It really is. And what I have told some patients in the past, and you have to make sure you take this with a grain of salt, is if you have a doctor that told you a specific age limit or a specific limitation for you, they gave you a window, a hard cutoff. Like if you don't get it done by this time, if you don't get your knee replaced by this time, then I'm not going to do anymore. What you have to realize is that one, take responsibility for your health and make sure that you improve it. That's on you. You know how healthy you are, how fit you are, because they may be thinking that maybe you don't have enough muscle on your body because you're going to lose muscle and being mostly bedridden for a while, barely walking a little bit the first week or two. You lose a lot of muscle within just days of being bedridden. So can you endure the rehab afterwards is what they're asking themselves. But two, the ability of your surgeon, because potentially you could wait beyond the window of time that your local surgeon gave you. But if you go to a place that has a more skilled surgeon, potentially they'll say, oh, we can do it in your 90s. It's no big deal. I've done it. I got a 100-year-old that I did a replacement on last week. You know, they'll have that kind of confidence because there are some superstar surgeons out there that will do a good job, but you have to make sure that that works for you, your specific situation. All right. So as far as too late, it's an individual thing, and it's mostly based on your physical condition, including your, any health conditions you have. Another thing could be deformities, like if you're really bow-legged, or if you're legged, or if you're really knock-kneed. Those do offer some complexities for the surgeon, so they might take that into consideration as well. But minor bow-leggedness, minor knock-kneed, usually isn't something that stops a surgeon from doing the surgery. It's when it's extreme. And then if you're really obese, that's going to be definitely something the surgeon's going to take into account, because then you're less likely to do the rehab according to them. And then just any other health conditions, heart conditions, diabetes, because that's going to affect healing afterwards. The surgeon's taking all this into account, but it's usually not an age thing. They just say that sometimes because what they see is the older you get, certain things just tend to happen. However, you can get healthier just by getting older, which would elongate your window. All right, guys, I'm going to answer some comments here next. Let's see who's here and what questions we got. Lovely Jubbly says, if x-rays cannot see cartilage, why have an x-ray? Great question. The x-ray does show us other things. So the closing space between the bones is an indication that you might have some cartilage loss, and there's correlation there. But the other thing that it shows us is sclerosis. And when you think of sclerosis, I wish we could pull up an image of this, but x-rays are black and white, and the bone looks white. The bone part looks white. When you see sclerosis, that means the bone near the surface of the joint is thickening. And then you'll also see something called osteophytes, which we all call bone spurs. Those are not normally seen in a healthy knee. Try looking up knee joint sclerosis or knee arthritis sclerosis. I'm trying to find an image for you guys. You'll see, bone spurs is what I was on. You'll see other signs. So sclerosis, bone spurs, and then any sort of like positioning, like bow-leggedness or knock knees, which you can see without the x-ray, but you get another picture, another angle of it with the x-ray. They put all these data points together, and that's how they're determining that you have arthritis. The other thing you have to factor in is an x-ray is very cheap to do compared to an MRI. And you don't have to go in a tube, which a lot of people have problems with doing an MRI. You have to stay still for 20, 30 minutes or more, depending on how many images you're getting, how many body parts you're going to do. And then you have to, it's just a longer process, and they cost, 10 times more or more. I forgot what the MRI going rate is now, but it's in the hundreds of dollars, whereas an x-ray you can get for under $100, depending on where you get it. But it's a lot more doable. So that's the main reason why they'll do the x-rays, because it's a cheap, easy, first, mostly predictable sign that you can use to diagnose x-ray to diagnose osteoarthritis in somebody's knee joint. We got a picture? Cool, we're loading up a picture to show you guys the sclerosis. Oh, that's a good one right there. So you can see there all the red arrows. The red arrows on the right side of the picture, where there's more of them, they're showing the sclerosis right there, how it looks whiter, like more bright not like a grayish white. It's more like a bright white. That's a sign that the bone is thickening right there. And then you have the osteophytes on the outer side where you have like that's the bone spur out there. And then the cysts are another thing that can form as well. So it's the bone just changing quality, and they can see that on the x-ray. But the spacing, in my opinion, is more the joint being smashed. And all those signs, by the way, the sclerosis, the osteophytes, so the bone thickening, the bone spurs, and the cysts are also signs of too much pressure going through the bone, because the way I interpret a cyst and osteophytes is that joint's being smashed, just like I have calluses. I got a blood callus right here on this one from lifting weights, because I'm grabbing barbells, I'm hanging from places, and so that pressure is going through that part of my hand, and my skin is responding by saying, let's get thicker there to protect it. And if I go too much too soon, well, I got a blood blister there, but you can rip your skin open and get to the surface under. But I'm trying to stay within the tolerance of my skin. I need these calluses to do the weightlifting that I do. And if you think of a knee joint that's got arthritis, it's responding to the forces going through the joint. And so it thickens in order to protect itself. The bone spurs happen as a result of tendons and ligaments pulling on the area, so the bone kind of grows into it, so it doesn't tear off the joint, tear off the bone. So all these are responses to too much force, which is consistent with my treatment approach. Great question, lovely Jolie. You got a two-part question? Two related questions, got it. So two different people kind of asking similar questions. How do you know if you have arthritis? Okay, that's from Aaron Munoz. And then Mia Doglove says, how do you determine if it's arthritis pain or hamstring pain? Ortho doctor told me I overextended my hamstring and wants me to do all the knee exercises. Good. Let me answer Aaron's question first. How do you know if you have arthritis? The number one thing that the medical field uses is that x-ray that I showed you just a moment ago. If you have all those signs or any one of those signs, they're going to officially label you as having osteoarthritis in your knee. It's usually the x-ray, in other words. So the doctor will get the x-ray. They have to order the x-ray because that's part of the diagnosis process. And then they get your information. They'll talk to you a bit. And if you're of a certain age, if you talk about symptoms in a certain way, like it's right around the knee joint, not too far up your leg or too far down your leg. If it's in the right areas, then they'll say this is knee osteoarthritis. That's the official diagnosis. What I look at is all those things. If we have an x-ray available, which we often do, patients often will show up with an x-ray or an MRI, and already have been diagnosed by their orthopedic doctor. But then I'll look at the muscle imbalances and I'll confirm. So specifically what I'm looking at is, are you quad dominant? I'll have people try to tighten up their glutes, and if they can't, I'm like, yeah, you're very quad dominant. Or if they try to tighten up their glutes and their thighs kick off, we'll also talk about like glute thickness. Like I don't even have to look at people's backs. I just have to say, do you think you've lost butt tissue over time? And they're like, oh yeah, of course. It's only gotten worse as the decades have gone by. I'm like, okay, we have glute muscle atrophy, or muscle loss in the glutes, which is what we have to strengthen to get the quads to calm down and not be so not compensate so much. So that's another sign for me. And I like looking at those signs because here's the biggest thing with a diagnosis, Aaron, is what should happen with the diagnosis is it should give us guidance on treatment. But when the medical field at large just says you have osteoarthritis in your knee joint, the treatment that ensues, what comes next, is try this pill, try this injection, go to PT and do whatever exercises they want you to do. And if none of that stuff works, which we're probably thinking it's not gonna work, then have a knee replacement surgery. You just kind of go through their treadmill or their the conveyor belt of treatments that eventually lead to a knee replacement. And then even after the knee replacement, people are still in pain, and people just give up, they acquiesce, and they're like, I'm just gonna have knee pain the rest of my life. Now, going to the other question about how do you determine if it's arthritis pain or hamstring pain? Well, they're related. I talk about the quads being the over-dominant compensating muscle for weak glutes, but hamstrings can also do that. So it's not uncommon for people to have quad pain or hamstring pain and also have knee arthritis pain. The main thing is, where is the location of pain? You can get referring pain, but that usually has to do with back problems, spine issues, nerve-related issues. So I would have to, differentially diagnose. Basically, I'd have to ask you questions. And if you have a history of back pain, then I have to assume there might be a nerve issue involved. But if you tell me, no, I've never had any back pain, never had any back issues, my back's been great, it's just my hamstring, it's just my knee joint, then I can kind of rule out all the back problems. And then I'm thinking you might have a hamstring dominance that's setting up your knee arthritis problem. You could just get knee irritation that doesn't show up on an X-ray yet as osteoarthritis. Like many of you guys that have arthritis have probably had this in years past, but it takes time to develop arthritis. You may have had a meniscus tear in the past. That's on the same spectrum of having knee arthritis. If you have patellofemoral pain syndrome or chondromalacia patella, those problems happen in 20s and 30s. Meniscus tears happen in 30s to 40s. Arthritis starts in 50s, 60s, and up usually. But it's the same root muscle imbalance that causes all of those problems. So it's all connected is probably the best answer here, Mia. I would focus more so on diagnosing the muscle imbalance and treating the muscle imbalance. Because like I said, the diagnosis is important to get right so that you have the right treatment. And diagnosing people with arthritis doesn't give them the right treatment because we've seen consistently the outcome leads to surgery. The outcome leads to just dealing with it and saying it's age. It's not. I would rather give you a treatment that does give you a positive outcome, and that's what we do. That's what we talk about all the time with like doing glute exercises, foot exercises, abdominal exercises, exercising the right way, making sure you fire right muscles. There's specifics to this, and you can calm down your hamstrings, calm down your quads, build up the glute strength, and depressurize the knee joint. That's what my treatment approach is focused on. Good question. GK, I'll just call you GK, says, I had broken patella surgery 7 years ago. I don't have any mobility issue, but my muscles are getting weaker year by year, and now I want to strengthen them, but I have pains when working out. What should I do? Oh, good question. Well, given the broken kneecap, there is a chance that your kneecap is just shaped different, potentially permanently, because you had surgery, this is my understanding, to fix that. So you just have to go through carefully to figure out what motions you can tolerate without your knee hurting more. And I would make sure that you're focusing on glutes, because if you had a broken patella, a kneecap, one of the first reflexive things that everyone in the healthcare field wants to do is say, oh, you broke your kneecap? Well, the muscles that affect it most are the quads. Let's exercise the quads. And you've probably been told, quads, 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 do quad exercises, go walk and shift your quad. That you've probably been encouraged and congratulated because you get your quads to tire out, fatigue, and get stronger all the time. When in reality, when you're getting those quads nice and strong, you probably have your quads strong enough already. It's just compressing that patella against the thigh bone more and irritating it and setting you up to get arthritis later on. But what needs to happen more so is we're going to get the glutes in the back of the hip working, because it controls the position of the thigh bone in the knee joint, which better aligns the patella on top of the knee of the thigh bone. So I would focus on glute strengthening and foot strengthening, because the ankle stability, the ankle position can also affect the knee, and that can take pressures down in the kneecap as well. So I wouldn't, if I were you, I wouldn't do any quad exercises or hamstring exercises. I would focus on glute exercises and foot exercises, because those are going to fix the imbalance and take pressure off the kneecap. Good question, GK. Another question from JT, medical research and longevity. I love that. That's cool. What about cases where patients have genetic predisposition for high inflammatory reaction, joint damage, weak collagen, folate metabolism issues? Can that affect the treatment plan? Absolutely yes, is the short answer. I am not a specialist in those kinds of things. My general answer is, if you have a genetic predisposition to inflammation, joint damage, all that stuff, that happens with all of us. Like, truthfully, there's certain races have genetic predispositions to certain health conditions. but it doesn't mean that you're going to get it. Hispanics, Native Americans, Blacks are all more susceptible to getting diabetes. We know this by research data than whites. Whites are more susceptible to getting skin cancer than all those other races I mentioned. There's certain sicknesses that affect certain people more so than others because of genetic makeup. I believe there are certain body types that are predisposed to getting arthritis, but if you have the right muscle imbalance, you probably won't get arthritis. Just like you don't have to get diabetes if you watch your diet and eat. You probably won't get skin cancer if you take the right measures to make sure your skin's healthy. So it's a what is it? What's the word I'm thinking of? An exposure problem. If you have certain levels of exposure, if you're not at risk for diabetes, in other words, you have more potential to be exposed to high sugar diets. If you do not have a high risk to getting skin cancer, you have more potential to being exposed to sunshine or things that can cause skin cancer. Same thing with arthritis here. So if you know that you have inflammation problems, all these things you listed here, wheat collagen, folate, then you need to compensate, take care of those things, but that still does not excuse you from the mechanical problems that lead to knee arthritis. So I would still work out your glutes. You still need to be worried about it. You just need to know that it's a little less, you have a little less margin for error. Hope that answers your question, JT Medical Research. Kimberly says, my IT band catches on my knee. I've been working so hard on the glutes, but don't seem to get relief. What with that leg growing an inch since hip TKR surgeries, maybe it's not possible if the leg is longer. That's a tough one, Kimberly. If you really, you've mentioned the leg length issue many times. If you really think that the leg length issue is a main problem here, I would put it to the test, Kimberly. I would go get a lift on your shorter leg. You can do this at a shoe store, custom orthotic places like where they make what is it? Like leg for people that have leg amputations. There are places in big cities that have special shops that make prosthetics, and those types of places you can take them a pair of shoes and they'll put an extra layer of rubber depending on what height you want it. They'll add an extra inch of rubber under your shoe so that your leg length is even as long as you have the shoes on. And I would try that out and see if you feel better with it that way. That's a lot easier than redoing the surgery. You don't want to go through that. But if you can add that extra height to your shoe, it may not even be that much. You might get an insole that's really thick, and you have to loosen your laces, make sure it works with your shoes. Try that out and see if it works better for you. Then I would still continue doing the glutes because you still need to do that. And keep going with that. That'd be my best advice, is try that out. You're kind of ruling things out, because if you get the shoe insert and you find it doesn't really make a big difference, and that kind of clears that out of the way, my approach with leg length differences, like permanent leg length differences, true ones, is overcome it with strength as much as possible. But you might need an external support. You have to test it out to see if it works for you. Some people don't do well with them, some do, but you have to try it out. Give that a shot, Kimberly. Guys, we have the helpline available right now. Call us. I want to talk to you if you have any questions. The number's right here on the screen, 915-200-4159. Again, that's 915-200-4159. If you're catching this in the replay, by the way, we won't be able to talk to you live, but leave us a message. We try to return all the calls to see if we can help you guys out. So give us a call. Let's get back to the lesson over here, guys. We're on number 3. We still got plenty more to talk about. We're covering the top 10 questions that everyone has about healing knee arthritis, and I was on number 4 here. Take a good look at my list. Oh yeah. What about weight loss? Does weight loss really make a difference when it comes to being able to recover from knee arthritis. And specifically, I want to talk about this 4-to-1 ratio that some doctors will mention. It's on the internet. There was a study done 20 years ago now where they used force plates. They took people that were overweight, people that were closer to normal weight, and they somehow measured the forces going through the knee joints and found that for every um, pound lost, it was like 4 times less pressure going through the knee joint. And now, to my knowledge, I haven't been able to find the full study available to me. So I would still want to look at the methods, but it doesn't. Based on the abstract alone, it does not look like they injected anything into the knee, like a force sensor into the knee. It looks like it was derived from computers. That being said, I think there's a high probability it could be inaccurate. It's a good sign, and it makes sense. And there are a lot of people that have lost weight and felt better in their knees overall. So it's not a bad thing. I'm not saying that weight loss, that you don't need to lose weight. I think you should. I think everyone could benefit from weight loss if you have weight to lose. Let me be super clear on that. And not just for knee arthritis, but for all kinds of other health benefits, for your heart, for your brain, for your kidneys. Your whole body will benefit from you being at a good weight. However, if you are a little overweight, maybe not morbidly obese, but you're overweight according to overweightness. I like to go off of BMI. Do we have the BMI chart available? I like to go off of BMI, which is body mass index. It's a ratio. There's the picture right there. It's a ratio of your height and your weight. And what you're looking at here with the different colors, red, orange, green, and blue. If you are in that orange section, green section, you are good to proceed through my treatment approach, and you're going to be just fine. Now, even if you're in the orange section, which is overweight, now if you look at the red section, there's some white lines there, and there's numbers on the lines. The numbers correspond to your BMI. What we have found going through the data of people in our programs, if you're at 35 or less on BMI, I can't give you a weight because you could be really short and you're versus really tall. Your weight's going to be relative to your height, but that's what BMI takes care of. If you're 35 or lower, people have success in our program. But once you're over 35 on BMI, over that first white line in the middle of the red section, then what I recommend is you do not do our program, and you should prioritize dropping weight. I think that's a really good plan for you. And if you're in that range, if your BMI is over 35, then you need to go lose weight. You need to go take serious consideration of what you're eating and your physical activity, all that stuff. And it's tough. I understand, because you might want to exercise more, but your knee hurts or other things hurt. Your back, your hips, your feet, whatever it might be, your shoulders. But you know what? If you focus on the weight loss, especially with what you're consuming, and get your BMI down, it'll be more comfortable to lose weight because you'll be able to exercise now. But we have just found consistently that if your BMI is over 35, it's not a good idea to be in our knee arthritis recovery program. I have the chart here. I show this all the time because these are the phases of our program. We talk a lot about this in our knee arthritis recovery program, but you shouldn't start on this yet until your BMI is 35 or under. Now, the reason why I bring that up, with the whole 4-to-1 is because I have patients in our program asking, well, my doctor said if I lose weight, I could fix my knee arthritis. And when I look at them, I'm seeing their face, I'm seeing their body, and I'm like, you don't lose a lot of weight. If you have 20 or 30 pounds to lose, and you're putting a lot of emphasis on losing another 10 pounds, another 5 pounds, the last 5 or 10 pounds to be at a normal, healthy weight, you might be missing out on improving your knee arthritis so much that losing that last few pounds is a lot easier if you're feeling healthy in your knee. So it would be better for you at a certain point, 35 BMI or lower, to now begin to focus on doing the right kinds of exercises to fix knee arthritis. So that's my question. That's my answer for weight loss is it really depends on how overweight you are. And I would calculate your BMI, which there's calculators all over the internet. You can talk to a healthcare professional. They'll be able to calculate it for you more often than not. And there's ways to find out on your own. and then determine for yourself, all right, I need to focus on weight loss. That's more important to me right now because I'm above 35 BMI, or I'm below 35. Let's go ahead and start our program, which, by the way, we have phase 1 of our knee arthritis recovery program for free. So whenever we talk to people on the phone or chat with people on the internet, we ask them BMI, and if they're over 35, what we say is go lose weight, please. Like, focus on that respectfully. Like, you need to do that. But you can work on our phase 1 for free right now. Do some of the things in there. The exercises are very easy and they shouldn't hurt you. But try that out to begin to get some relief now, to get your pain to come down now. By the way, there's the comment that's highlighted there. That's a link to the recovery, the first phase of the knee arthritis recovery program. You can click on that link and the page just loads up. You don't have to log in. You don't have to pay anything. You hit the play button on the videos. There's a little video player, and you'll see a list of videos in the main video. You can hit the expand button to fill up your whole screen if you want. And you can start going through phase 1 of our knee arthritis recovery program right now, regardless of your weight. But just keep that in mind. 35 or below, less than 35, then that means you're good to start rehabbing your knee with exercise. But if you're above, you need to lose weight first. Right, number 5. How do I get strong without more pain? I love this question. The other ways that people ask it are how can I strengthen my knees without causing more problems? How can I exercise to get stronger without causing pain? They're asking this question from a place of, when I exercise, it hurts my knee. And I'm confused because some people say I need to push through the pain and continue to exercise. I need to make my muscles work and burn, fatigue, but my knee hurts as I'm doing it. So how is this right? They have some tension inside about it, and that's where the question comes from. And here is my opinion. If you're hurting, there's 2 problems to consider. If you're hurting during exercises that are supposed to help your knee arthritis, number 1 is listen to the pain. Stop what you're doing. Adjust what you're doing. That pain is a clear sign that you're irritating something inside your knee, and you shouldn't do that. Now, notice I said stop or adjust, because if it's a good exercise, you might need to just adjust it by doing less reps, doing it less intensely, bring the weights down, do a lighter version of the exercise, and you could probably get away with doing the exercise. But the other one is it might just not be the right exercise for you at this time or ever. So a good example of a never exercise, in my opinion, is a quad exercise, like doing a knee extension. Let me show you over here what I mean by that. Sometimes in physical therapy, you'll have to do they'll tell you to do an exercise where you just straighten out your knee and you're focusing on getting this muscle to tire out. But I've said in my explanation of the muscle imbalance is getting this muscle stronger compresses your kneecap against the thigh bone, and that's a bad thing. So it doesn't make sense to do this exercise more, especially if it hurts your knee joints. Not a good thing. You shouldn't be doing this one. But then I say things like do glute exercises. Figure out how to use your glutes while you're walking. Those are good things. But what if you have knee pain while doing those? So then what you have to do is figure out, am I doing the exercise correctly? Am I feeling the right muscles burn? Because if you're doing a glute exercise, but you don't feel your glutes working, you're doing it incorrectly. One of the best pictures I can give you is if you've ever been to a gym that has a bunch of machines, where it has the stack of plates and you put the pin and the weight that you want, and then you sit on the machine and you do whatever. There's usually a picture on the machine of like a man standing like this, and it's got like muscles that are highlighted. They're colored, red or yellow, whatever the theme of the machine is. And that picture is indicating to you which muscles you're supposed to work. I love those machines because how often does it actually target what it is? Probably most of the time. But when you go do a glute exercise and you felt your hamstrings mostly working on the back of your thighs, or you felt your quads working in the front of your thighs, or your hip flexors working in the front of your hips, and you didn't really get your glutes, then you're doing the exercise incorrectly, and you need to go refresh on how to do that exercise. And you might need some specific help. And not all healthcare professionals are prepared to help you with that. That's the truth. They'll just say, go do that bridge and leave and expect that you did a bridge. It looks like a bridge. Mostly for the most part, it looks like a good, decent bridge, but they didn't check in with you and say, did you actually feel your glutes working? Because it's possible to do a bridge and not use your glutes. Then we're training the wrong muscles. It's possible for you to do a squat and never use your glutes. Barely, if anything, use your glutes. And always use your quads or your hamstrings, back muscles. That's when you run into problems. So how do I strengthen without more knee pain? Focus on using the right muscles and adjust the intensity so that you're not overdoing it. Because if you're going back to my phases chart here, the way, just so that you know how this works, this is these are the 4 phases of knee arthritis recovery. This is all part of my program. If you do our free phase 1, you'll start learning about this more in depth. But basically, the first phase, we're worried about you getting the pain under control. Here in the second phase, we're starting to fix the muscle imbalance a little bit and getting rid of the last bit of pain. By the time you're in phase 3, you're feeling amazing, and we're heavily fixing the muscle imbalance here. And then in phase 4, we're strengthening and doing more normal everyday things. So when you're doing exercises from phase 3, where we're heavily fixing the muscle imbalances, but you don't qualify to be in phase 3, you don't have all of these boxes ticked here, all these criteria ticked, and you have a criteria from phase 1 that's still lingering around, you shouldn't be doing phase 3 stuff. That exercise, even though it's a good one, is too intense for you because you're in phase 1 or phase 2. And so even a good exercise can be harmful if it's done at the wrong time. So there's a little bit of a strategy to this, a little bit of thought, a little bit of learning. That's why we have a whole program dedicated to this, because one of the first things you do when you enter our program, one of the onboarding things we do, is you need to go through all the education videos, because I essentially tell everybody you need to get a small degree, an associate's degree in healing your knee arthritis, because if we're going to fix this problem for good, so you're not having a knee replacement surgery, you need to learn a few things that are just embedded in your head, so that when things go wrong, when your knee flares up, when it starts to hurt, you know what to do. And we have a test that you have to take, and it's not hard, and you can take it as many times as you want. But once you pass it, then we have confidence, and you're probably going to have a lot more confidence. You know our treatment approach very well, and you can safely progress to the program a lot better. So if you're thinking of joining the knee arthritis recovery program and you're not into tests or you're not into learning stuff, please don't join. Please don't apply to join our program. We only want people that are really going to be learning this stuff and taking it to heart, because that's what it takes to avoid the surgery. You might actually be a surgical candidate at that point. It might be better for you to go ahead and get the knee replacement done if you don't want to learn anything, because that's what surgery is. You don't learn anything. You just show up, they put you under anesthesia, it's completely passive. You have to do the rehab afterwards. That's part of the process, which it's active on your part, but you don't have to think much about besides what the therapist is telling you to do. Just do what they tell you to do, basically. There isn't a whole lot of thought process behind it. My program does require a thought process. Just want to be blunt about that, because I would not like to lie to you. I want to tell you right now what you're getting yourself into. It's not an easy program. It's not a super. We've simplified it as much as possible so that you don't have to have a medical degree to understand this stuff. But I tell you, we have doctors in our program. We have, I mean, you have to meet them as you go in. But anyways, that's my answer on exercising. Make sure that you're not overdoing it. Make sure that it's the right exercise, you feel in the right muscle, and then make sure that it's the right time for that exercise. We're going to number 6 here next. Okay, let's keep going here. We're making good progress. Number 6. Oh, this is a classic one. I'm just going to write age. Isn't this an age-related problem? I get that all the time. I'm 72. Is there really a chance my knee arthritis is going to improve? But the doctor said that this is an age-related problem. Can I actually heal knee arthritis if it's an age-related problem? By that logic, no, because as you become 73 if you're 72 or 83 if you're 82, if it's truly an age-related problem, then you have zero control because nobody can age reversed. You always age up, you always get older. And if it truly is an age-related problem, then you technically should be getting worse and worse and worse in your knee arthritis. And I disagree with that wholeheartedly because I see people going through our knee arthritis recovery program, and time only moves forward in our world, and we only age, yet they get better. Therefore, we're breaking the rule. We're not getting worse as we age. We're actually improving as we age. But the reason why the doctor says that, because that's probably the next question you might have is, well, how come the doctor said that it's an age-related problem? Is you have to see their perspective. They're not teaching people to fix muscle imbalances that are the root problem of knee arthritis. They're instead guiding people through this conveyor belt of treatments that everybody gets. Let's try the pain medications. Oh, that didn't work. Let's move to the injections. Didn't no luck there. Let's try the physical therapy. Only got worse. All right, time for surgery. I was expecting this anyway because it's an age-related problem. Feeds their expectation. And if everybody that they're treating with knee arthritis kind of goes through that pattern, what do you think the pattern that they develop is and that they impart on you when you're the next patient in their office complaining about knee pain? All my patients just got older and they all just got worse, no matter what we did. We have state-of-the-art treatments. We have this brand new medication that Pfizer spent billions of dollars to produce, and we have this injection that's state-of-the-art, and it's reproducing the gel inside your knee, the components of your knee fluid. And we have these physical therapists that are all doctors of physical therapy now. They got to know what they're doing. And then we have this surgery, and it's state-of-the-art too. And we have all these surgical parts, and the surgeries, the rates of improvement are going up, and yet people still get worse even after surgery. You have to realize the perspective of the doctor is that people with arthritis tend to get worse. What's missing from their treatment is fixing the root problem. I mean, they're doing it in other realms too. It's not just knee arthritis. It's not just arthritis in general. Think about the obesity problem in the United States. We have all kinds of medications. Focus. You guys know the medication that everybody's talking about that's making people lose weight. We don't know what the side effects are going to be. This is a brand new medication. But we all know that eating right, exercising does help you lose weight. It's just effort and work to do that. You don't get to enjoy cake. You can't just sit and watch TV all day. You got to go put in some effort to restrict what you're eating and make sure that you're being a little more active. It just takes effort. And so it's a similar, I'm just letting you know that this is what happens in the medical field. We're not focused on fixing the root problem of big health conditions out there. We're more focused with short-term treatments. So age, I highly disagree with. It is not the cause of arthritis. I get passionate about that. It's fixable for most people. All right, guys, we had a call on weight. We're talking to Kathy from Long Island. Thank you. Hey, Kathy, this is Dr. David.
Hi.
Nice
Hi, I'm
to
good.
meet you.
I do so enjoy listening to all your advice. It's really good. Just a quick question.
Sure.
I have limited range of movement in my body due to arthritis, and I was talking to somebody earlier, and they'd have these gel shots that had helped for a certain. I think they're going to have to go for the replacement. But would you recommend those to sort of feel the pain a little bit when I'm just trying to increase the range of movement?
Yeah, great question. Sorry to hear about your problem, by the way. With the gel shots, I'm okay with people getting injections and trying out pain medications as long as you understand that it's not fixing the root problem. It sounds like you're wanting to use the shots to give you some temporary relief so that you can go get to some of the exercises and the activities you want to do. If that's the case, Kathy, then I'm all good for it. What I just don't want you to end up in is that conveyor belt of treatments that I talk about where Let's try the injections. Let's try the medications. And so, yeah.
Sometimes when you're hurting, you try and protect yourself, and
Yeah.
some of the things I'm trying to do to increase that range of movement. Yeah, I hear when you say about strengthening the glutes.
Yeah.
But it's just like I can't kneel down on that knee anymore, and it's just like bending a sausage, trying to bend a sausage down.
Yeah, I get you. I get you completely. And so, yeah, I think that's worth a shot. You can try that out. No pun intended. It's worth a try to get the injection and see if your pain is reduced so that you can tolerate a little more exercise. And then you just have to see if it's right for you, if to continue to get shots or try something else. Main thing I would be worried about is fixing that root muscle imbalance, fixing the glutes, getting the feet stronger, and getting your abdominals stronger. But if you have that understanding, I'd say give it a shot.
Literally, yeah.
Literally. Hope that helps you, Kathy.
Thank you so much. Thank you.
You're welcome, and thanks for watching. I appreciate you.
Oh, you too. Thank you.
Thanks. Bye-bye.
Bye.
Cool. Excellent question from Kathy about getting an injection, and I was so punny there. I didn't mean to be, but anyways, yeah. As long as you have a good understanding that the injection is not fixing the root problem, then you have that awareness, and that's my goal for you guys, is that you can go through mainstream medical treatments and understand its place in your rehabilitation, and understand that there's deeper levels to this, that it is possible to heal arthritis if you fix the root problem and not just rely on you can't rely on the doctor to know how to fix a root problem. That's kind of the takeaway message. They're going to recommend treatments that are just short term, and because of that, you're not really going to fix a root problem and end up with surgery, and that might not even help you out long term either. So good job, Kathy, on being aware of that. All right, we're going to answer some comments here next. Who do we have first here? Lorna says, I missed it. What should your BMI be before exercising your knees? Oh, that's easy. Lorna, 35 or lower. If you're at 35 BMI or lower, you're good to go through our knee arthritis recovery program. You're probably going to be successful knocking out your way through the phases without ever losing a pound. But if you're over 35, then you should focus on getting your BMI down under 35, 35 flat or under, so that you can get into the program and begin to get the benefits of fixing the knee arthritis, which is going to help you to continue to lose even more weight, if that's your main goal here. So just be aware of that. And just understand too that BMI is a general measure of your height and weight. If you're very muscular, you might have a BMI. Like, I mean, I could stand to lose some body fat, but I have some muscle too. So my BMI is kind of on the higher range. I'm actually in the bottom red section. My BMI hovers like in the mid 30s. I'm sorry, not like 31. 30 or 31 is my BMI. But I lift a lot of weights. I ran 4 miles this morning. Like, I'm an active individual for sure. I work out virtually every day. I think I miss 1 or 2 days a month on exercising. And I don't overdo it. I listen to my body, and I don't do extra long workouts. It's just a matter of you figuring out what your weight is and where your BMI is. I'm happy to answer any questions about that, by the way, if you have details regarding your BMI. But those are the numbers, 35. All right. Mewtwo says, how can you do bike by pushing from the glutes? I tried it, but I don't get it. Should I put down the bicycle saddle? Good question. Usually having the bike seat, the saddle, relatively higher tends to be better, because what you want to do, I don't have a good bike here, but if we can show on the side camera here, what you want to do, if you focus it on my leg here, is if you just think about my left leg being in the bike, by the time your knee is about this position right here, that's where the down position of the pedal should be. So adjust the seat height so that when you're in the up position, you pedal down, your knee has a slight bend in it. If your seat is too low, then your knee's going to be at this position, and it's harder to get your glutes to activate if you're in this position. But if your knee goes down about here and you're cycling like this right here, then it's easier to get your glute to activate on the downstroke when you're pushing down on the pedal. That's where you should feel the glute activate. Now, if you're still having trouble with it, I've got videos on it. So, search bicycle El Paso Manual Physical Therapy or cycling El Paso Manual Physical Therapy. I might have videos. I think I have one on chondromalacia patella. I do have one on knee arthritis as well, possibly one for hip arthritis. But practice. That is the biggest thing that I see. Like, it's similar to glute walking. You should be able to walk and activate your glutes well. If you like to bike, you should be able to bike, activate your glutes well. Same thing with elliptical. If you like to use elliptical, swimming, you should be glute swimming. When you kick with your legs, it should be glute driven. And then what's the other one? Running, cycling, running, walking, and swimming. Those are the big ones. There's an elliptical was the other one. All of those you need to be involving your glutes. And if you can't figure it out, it's usually just a matter of reps. You need to practice more. You need to slow down. What a lot of people do is they're trying to get a workout in. And what you need to do is slow down, stop focusing on burning so many calories and getting the sweat, and focus on just getting the muscles to work right. After a time or two of doing that, maybe a week or two of doing that, then you can start to go faster and get the sweat you're looking for, burn the calories that you want to burn. Slow down, do more reps. Good question, you two. Who's next here? We got Marine. She says, "Hi, Dr. David, walking with glutes, core, and toes. I love it. But my glute medius has become very tight. What to do? Also, is it okay to stand with lower abs and glutes engaged?" To answer the last question, yes, it is okay to stand with your lower abs and glutes engaged. It is encouraged to stand that way, in fact. What it sounds like you might be doing, Marine, is potentially overdoing it, because as you use your glutes more and more, there's a certain rate at which your strength will increase and allow you to use your glutes more. And if you're exceeding that rate, your body starts to overcompensate. And so you might use the muscles on the sides of your hips where your glute medius is, maybe even the TFL muscle. That's a common one that starts to overact. You start to co-contract with it. And so you might need to just slow down a little bit, reduce the intensity, start to calm it down a little bit, and I think you'll be just fine. Sounds like you're overdoing it, Marine. All right, so we got a call. We're going to talk to Susie from Colorado with a knee problem. Hey, Susie, are you there? This is Dr. David. Hello, Susie, are you there? This is Dr. David. Oh, Susie, are you there? This is Dr. David.
Hi, Dr. David. Thanks for picking up.
So sorry, I had you on mute. I was trying to talk to you, and I was like, oh no, Susie's not there. Glad I got you on, Susie. How can I help you?
Well, I am 72, very much deconditioned, BMI 36.
Oh, you're right on the edge.
I know, but working on losing weight.
Good.
Definitely have knee arthritis in both knees, left over right. Certainly working on reactivating the glutes and trying to get them to wake up.
Yeah.
I can certainly activate them sitting or standing, but I don't really, it's hard for me to activate them when trying to sit to stand exercise or going up steps exercise. And every time I come to bridge, for example, my hamstrings cramp up. So I guess, where do I start? Other than we know the weight loss that is just start with walking, or what other exercises I might be able to do to accomplish all the goals I have.
To fix your knee.
Supporting my knee.
I get you. Well, let me ask you this: is what you're doing so far with activating your glutes, has it helped your knee? Your knees?
No, because I don't think I'm doing it effectively. When I go upstairs, for example, I feel it on the side of my hip.
Okay.
And I try to activate them, but it seems like they just lessen up, and I can't keep them tight for more than like a step or so. So I think I need to do more of that without somehow hurting them, like bridges or whatever. But can't do that because the hamstrings cramping. So
it sounds to me like when you're doing the bridge, if you're getting hamstring cramps, that's a very clear sign that you're overusing your hamstrings when doing the bridge. And so that means that you're probably not able to activate your glutes enough. So you're lacking strength, coordination too. The fact that you're saying that the knees that it hurts you in your knee and your hip going upstairs, that stairs just require more strength. So that's going to be in my mind, you're probably still far away from being able to effectively do stairs without pain. You might reduce the pain on stairs, but you're probably still going to have pain, especially if you're telling me that your bridge is still hamstring dominant, making your hamstrings cramp. So yeah, obviously, drop the weight. You probably don't have much to go. If you're at a BMI of 36, you might be 5 pounds or so away from hitting 35. But you probably need to stick to phase 1, maybe phase 2 activities. Now, phase 1 is free. We have that on the website. And if you go to the website for phase 1 for the knee arthritis recovery program, where it's free, I would make sure you do everything there thoroughly. Because if you're not ready to get out of phase 1, going to stair climbing, that's not until phase 3. So you're actually getting ahead, and that might be why you're not feeling like you're progressing as much. You might need to just stay in your phase, if you will. That's how I designed the program, is you don't go to phase 3 or 2 until you're absolutely out of the woods of phase 1. You confidently don't have any more of the criteria for phase 1. Then you go into phase 2. So bridges might even be a little rough for you right now because I don't know. We don't do bridges in phase 1. That's actually a phase 2 exercise. In phase 1, it's just glute activation, lots of it. The other thing that we're doing a lot of that I don't know, you haven't mentioned this, is offloading. How are you with offloading?
I don't offload at all, other than, of course, with steps and all of that now, I rely heavily on the railing also for balance.
Yeah.
But I don't think I know how to offload.
Go check out phase 1. There's the videos are there. They're for free on the website. And I will teach you all about offloading in phase 1 of the knee arthritis recovery program. Yeah, I'd say that's your next step. Wonderful. Thanks for calling. That's good that you got that cleared up because, yeah, if you're just trying to pursue the stairs and other things, you might run into more pain and say, this isn't working for me, but I'm glad to be able to clear it up for you on the phone here.
I really appreciate it, and I'll be looking forward to phase 1, and thank you so much.
Absolutely. Stay in touch with us, please, Kathy. Or Susie, right? Sorry. All right. Thank you. Yeah. Bye-bye, Susie.
Bye.
Getting all our callers confused. Kathy called first. She was in Long Island, and then this was Susie. Sorry, Susie, that I called you Kathy. And Susie's in Colorado, is my understanding. Colorado's so beautiful. I visited for the first time in a really long time recently. Got a little skiing in, and beautiful place. I had such a great time. All right, so we go into the lesson, right? Let's go to number 7 here next. We just talked about age, and I disagree staunchly that arthritis, knee arthritis especially, hip arthritis too, that they're age-related problems. It's just that's what the healthcare profession sees, and so they assume that. But it's fixable. We see people all the time get better despite them getting older. All right, number 7. Oh yeah. Losing. There we go. What is the biggest regret from people that have had surgery? So I'll say from TKR. TKR is total knee replacement. You might have seen that if you're considering getting a knee replacement. There's different kinds of knee replacement, but a total knee replacement is by far the common one that people get. And so I get people that ask all the time that are kind of on the fence or thinking they've been told they bone on bone and thinking they really need to go get a knee replacement. They ask me, what is the biggest regret that you hear from people that have had a knee replacement? And I got to say that more than half of the people that I've talked to that have had a knee replacement, because I'm thinking about everyone, like people that are coming in to see me for a shoulder problem, a hip problem, a back problem. Sometimes they have had a knee replacement in the past, and they're like, "Oh, I feel fantastic. I'm so glad I got it done." And at that point, I give them a high five and I tell them, great, glad. Just make sure you get those glutes working. Make sure you still stay strong. And for the most part, people that I see, they're on top of their health. They're trying to get back in shape and make sure that their body's working well for them. But for those that have continued to have problems, because there's a lot of people the other half of the people that I see, they I've had so many people with problems from a knee replacement that I actually made an online program for it, and I've got a lot of YouTube videos for it. They're on having a failed knee replacement or a knee replacement that still bothers them. They still have knee pain, and they're kind of left in this middle space of, what do I do? Because if it's not incapacitating for them, if it's not debilitating, they can still walk, they can still do stuff. There's limitations often, but it still hurts them when they sleep. It hurts them to walk too much. They can't do certain exercises. They can't kneel. There's a lot of, I can't do this, I can't do that. They're restricted to, well, I just walk short distances. I do what I can. I really have to watch what I eat, because if not, I'll balloon out because I'm not exercising because my knee doesn't let me. So their biggest regret, the number one thing that I hear is not fixing the muscle imbalance. So I'm just going to write no muscle imbalance. And they're doing the corrections with me afterwards, because it's still possible to fix the muscle imbalance even after you've gotten the knee replacement. You can still get your glutes stronger. You can still get foot muscle stronger very often, and abdominal muscle stronger, and that takes pressures off everything going through the knee joint. And even though your joint's been replaced, you can still make improvements. The trouble is that by the time you've had a knee replacement, a lot has been done. You've got a big scar. You've probably lost a lot of strength. You've gone to the rehabilitation afterwards, which is usually focused on developing your quads, which is necessary right after having a knee replacement, because the quads are often shut down. But then we have to shift over to the muscle imbalance corrections, and that doesn't happen normally through the rehabilitation after the knee replacements. Then you have some extremes of people that have had a knee replacement, and they have had a nightmare situation. There's a minority. It's not a lot of people, but there's a fraction of people that they're like, I wish I would have never had the knee replacement done, because they got an infection or they had a reaction to the metal of the prosthetic, and then they had to have it revised. They had to have a second knee replacement done. Some of them had to have a spacer put in, which is what they do with an infection, obviously. Sometimes if you have a really bad infection from a knee replacement, which happens from surgical procedures, sometimes the aftercare, there's a variety of problems. It might be your surgeon, it might not be your surgeon too. But then they'll have to remove all those parts, and they'll put in a plastic piece to just hold the bones, what's left of your bones, in place for you to get over the infection, so that you can then do a second knee replacement. That's called a revision, and you're bedridden all that time. You can't walk. You have a spacer in. You're not moving around a whole lot. Imagine going to the bathroom like that with your legs straight and your leg kind of open. There's all kinds of nerve problems develop afterwards, chronic pain issues. People just are sometimes severely traumatized after having a knee replacement that didn't go well. But in my mind, there's a chunk. I don't have a good space to draw it. If you think about the people that have knee replacements, this is from my perspective. Okay, about a third of them, it's not exactly, a third of them do good, like really good. They're very happy. And then, it's probably a little less than a third. Let me redraw that line. I don't know what the exact percentages are. Like I said, this is my opinion. I'm just giving you my eyeball estimation of what I've seen. Probably more like half of the people. I'll use the blue one. They're unhappy. I'll put it to you that way. They're tolerating their knee replacement. They're not going to go get a revision. They don't want to deal with the doctor again. They don't want to deal with anything, but they're just kind of unhappy. And then there's a small, tiny fraction of them that are they have a miserable time. They have the revision. They are worse off now. And then there's this third that's like super happy. And then there's this big chunk right here, like the middle 3/5, if you will, that they're like, well, it's okay. I can walk. I can go to the grocery store. I have to lean on the shopping cart, but they're not fully content. And they never tell the doctor. When they see the doctor, they're usually saving face. They're like, "Good job, doctor. I can bend my knee better. I can walk now. It was really bad before, like really, really bad. It's definitely better than them." But what they don't say is, it's not what I expected. There's a lot of things I'm never going to dance. I'm never going to hike. I'm never going to go sightsee and do the walking trip to Europe, or to the Grand Canyon or Yosemite or whatever it is he wanted to go do. I'm never going to go walk to New York. I'm never going to, I'm going to be often looking for a place to sit whenever I go out. That's kind of how they live now. They just give up and settle right there. That's that big chunk of people. And then you have the chunk of people that are the extreme bad, and then the people that are good. That's what I see. So that's the biggest regret, is that they wish they would have done something else, but they didn't know what to do. All right, moving along. Let's do number 8 here next. I might run out of room. Why didn't PT work for me? There's people that go to physical therapy, because they don't want medications. They don't want the injections. They don't want the surgery. And they know that there's benefit to exercise. And they're determined. They're like, I'm going to fix this knee arthritis problem. I'll do whatever the therapist tells me to do. I'll do double what the therapist tells me to do. I'll work real hard to make sure this gets fixed. They go to physical therapy, and physical therapy says, yep, come on right in. Doctor sent you over. Let's hop on the treadmill. Let's hop on the bike. Let's do these quad exercises. They'll run you through your paces. They'll have you do plenty of exercise. But what most people don't realize, going to physical therapy and they end up getting hurt, is that most physical therapists out there are not specialists. The vast majority are not specialists in helping you avoid surgery. The vast majority of physical therapists out there that you're going to see if you have a knee arthritis problem, they specialize in helping people after surgery. And the proof you can look for if you go to a PT clinic is look at the patients that are there. Ask them, talk to them. The therapist isn't going to tell you what everybody's here for. They shouldn't be. That's HIPAA violations. The doctor's not going to tell you. But if you find a friendly patient who's willing to talk to you and you just ask them, what are you in for? What are you here for? Probably 6 or 7 out of 10 of them are going to say, I had a surgery. That's why I'm here. But what you have to realize too is that the physical therapy clinic is not they're not going to have the self-awareness to tell you that they suck at helping people recover from knee arthritis without surgery. Because most healthcare professionals out there, 9 out of 10, 99 out of 100 of them, I would estimate, they're do-gooders. They want to help people. They're trying to do the best that they can with what they know, but they don't have the honesty and the realization and the clear evidence from patients that they are not good at helping people avoid surgery. And what sadly happens a lot, if you're going to try to avoid surgery with PT, is you have a certain amount of time that insurance has authorized you or the doctor has told you to try physical therapy for. And if you hit that time frame and you haven't made significant enough improvements, that therapist very often is trained to tell you, you know what, physical therapy isn't right for you. Maybe you're too old. Maybe it's not going to work. You should go have surgery. Let me send you back to your doctor to see what the next steps need to be. They give up because they don't know. They're not experts in that. That's probably why your PT didn't work. And you probably have a super nice therapist. And I'm a physical therapist myself. Like I'm speaking from my own profession. I taught in PT school. I've taught many therapists. And I will say they are excellent. If you had a surgery, go see one. You're probably going to get back to feeling active again and doing a lot of things that you didn't do before. It's going to help you if you have had surgery. But avoiding surgery, the information that I'm teaching about here, muscle imbalances, the whole concept, it's not taught in schools. It's not in the research yet. So therefore, you're not going to get it from a typical physical therapist out there. That's why PT didn't work. I'm going to keep going here. Right, number 9. Just check on that team, make sure we're good on time. I'm going to squeak it in here in the bottom. Oh, this is a good one. Am I damaging my knee every time I take a step? Am I damaging my knee every time I feel pain? I love this because you guys with knee arthritis, you catch a comment from a healthcare professional that they probably didn't intend that way. Sometimes healthcare professionals believe it too, which I think is ridiculous, but they'll make comments like, you're wearing your cartilage away, your cartilage regrow, You're wearing your cartilage away every step you take. They'll make a comment like that. And I don't think they mean it literally. I think they mean it like for the most part. But how do you walk out of your bed in the morning to the bathroom and to the kitchen and to work if you work and to spend time with your loved ones? How do you take care of your life if you cannot walk? And so it's false to think that you're damaging your knee every step you take unless you have not fixed the imbalance. So if you haven't fixed the imbalance, then potentially you're damaging your knee every step you take. But what you have to realize too is that the knee can heal. It has the potential to heal. It's a living tissue, and you develop scar tissue. You can heal injured tissue. So it can heal, and you're not just limited. You don't have a limited number of steps. I heard a story one time from somebody telling me that the doctor told me, or the physical therapist, I forgot who, a healthcare professional told a patient of mine that I have a limited number of steps, that you have like 1,000 or 10,000 steps left before your knee needs to be replaced. And so they were literally trying to avoid walking on the leg because they had this belief put in their head because they don't know how the body works. They don't have an understanding of the medical field and anatomy and physiology and all that. And they don't have to. It's okay. But we have to have an accurate understanding of how the body works. And it does heal. You're not limited in steps. And the other thing is, if I feel pain, am I damaging your knee? No. If I scratch my skin too hard, I can make it red and irritated and feel pain, but my skin isn't damaged permanently. It will heal. The redness will go away. Even if I cut my skin open and I bleed a little bit here, and I scrape myself on things all the time, and I get a little nick, a little cut, it heals. It's not a permanent thing. And it might be scar tissue. I might have a scar, but scar tissue is still very functional for our bodies. That's why we're designed that way, to scar it over. So I would forget about this worry if that's a concern of yours. Is my knee being permanently damaged every time I take steps or I feel pain? No. You have irritation that can go away. And if you don't have any pain with steps, then you're not worried about irritating it. You probably have many infinite amounts of steps, as many as you're alive. You just have to make sure that we fix the muscle imbalances long term. That's the caveat. All right, nearing the end here, number 10. Oh, I love this one. I'm just going to write this one word. What about walking? The question that I get, to read it off specifically, is why does walking make my knee worse even though everyone says it should help me? Everyone pushes walking. When I say everyone, the medical field. Your doctor told you to go walk more. Your physical therapist told you to walk more. They have you walk. As soon as you get there, it's jump on the treadmill for 10 minutes and warm up, or jump on the treadmill for 10 minutes and cool down. Start a walking program is what the doctors often say. It's a step in the treatments before you go for the knee replacement very often. It's to try a walking program. And they tell you to count your steps. And people get the pedometer, or they get the smartwatch, or they get the app on their phone that counts their steps, and they keep tracking the numbers. Oh, I got 5,000 steps today. I got 7,000 steps today. And they're trying to push more and more steps. And then there comes a point, if you have knee arthritis, where it feels better because you're walking, but then you keep going. You get to 9,000, 10,000 steps very often, and then it starts to hurt. The knee gets worse at a certain point. This happens consistently. And there's a little bit of research starting to come out. There was a lot of research that said walking more in general helps knee pain, even knee arthritis. And I think the reason why that happens is because very often people that have knee arthritis have reduced walking because it hurts. But getting some activity, if you've not been doing any activity, generally feels better. You're outside, you're talking to people, you're seeing the outdoors, you're in the mall walking, you're kind of doing fun stuff. So you forget about the pain. But then you get to where it gets hard, and it's like, okay, well, 2,000 steps, 5,000 steps, it's a relatively brief walk. It's not that long, a couple miles, 30 minutes at most, 50, maybe 40 minutes at most. But now if you're going to push to 10,000 steps, it's going to take you over an hour. It's going to take you 2 hours to walk that. That's more like 5 miles. And it gets tiring at that point. And if you have these root muscle imbalances, which you probably do if you have knee arthritis, then you're quad muscle dominant, you're using the front of your thighs, these thigh muscles right here, and all those 10,000 steps of dominant quad muscle is just rubbing and irritating the cartilage because you get extra compression from the kneecap onto the thigh bone, and then it's yanking the shin bone down here up against the thigh bone every time with extra compression because it's over dominant quads. Yeah, you're going to irritate the knee joint. So we have to take some steps back, no pun intended again, to fix the muscle imbalance to get the glutes stronger so that when you go walking, you're doing a glute dominant walk. You're using your glutes every time you walk. Let me show you what this looks like. So in case you've never seen this, this is really important for you to understand. When you take steps, are we good over here? When you step on a leg right here, like I'm stepping on my left leg, you should tighten up your left butt cheek. Your glute muscle over here should tighten up a little, like 10, maybe 20%. And then as you take a step with the other leg and you bear weight on your right leg, my right foot here, then I should relax this left side and tighten up the right cheek. And you should be alternating steps every time. So if I show you the back side, as I step on this leg, this glute should tighten up a bit. And as I step on my other leg, this glute should tighten up a bit and this one relaxes. So essentially you're alternating glute contractions every single step that you take. You're tightening this one and then this one, which is advanced for some of you guys. Because some of you guys, you try to tighten your glutes and your quads activate and your glutes do not. If that's you, you shouldn't be walking for exercise because you're quad dominant. You're going to irritate your knees. That's why walking causes more pain for you because you haven't figured out how to use your glutes right. And some of you guys have some glute activation, but you can't separate your left from your right. And that is necessary in order for you to coordinate the right muscle usage as you're walking. We don't talk about that until in our program until the end of phase 2. That's where we start glute walking. By the time people move out of phase 2 into phase 3, they're new glute walkers. Then we introduce stairs here, how to use the stairs properly, because you need a base layer of strength to do the stairs. And hopefully you've been doing some glute walking already to build that strength along with other glute exercises so that you can take stairs better. But all too often, people that are unaware that they're in phase 1, they don't have good glute activation. Can y'all see that right there? It says right here, let me read it out loud. This is the criteria for phase 1. Glutes. If you cannot flex or tighten your glute muscles, other muscles flex instead. In other words, you try to tighten your glutes and they don't work. And your thighs work instead. You're sitting in the doctor's office and the doctor has not assessed your glutes because they don't know to. This is not the training. And then they recommend a walking program. You need to start getting 10,000 steps in. And then you trying to be the good patient says, aye, doctor, let's go do it. And you go start walking, never thinking about your glutes, you're going to run into knee pain. That is why walking hurts more. All right, guys, hopefully this helped you out. We got 10 questions here. Where are we going to next? We're going to talk through some comments. What questions do you guys have so that we might be able to help you out, get you unstuck here? Let me know if this was beneficial for you as well, guys. If going through these questions was helpful. I really want to know if I answered a question here that you didn't know you had, but you're so glad that I covered it. That would be really helpful here. Dr. Liz Lyons is here. Fantastic. She says, I used to use my elliptical daily and then select off. Should I go back to doing the elliptical even with hip arthritis if I do it slowly along with other exercises you outline? I love this, Dr. Lyons. If you can use your glutes on the elliptical, if you can do glute ellipticaling, like I talk about doing glute walking and glute stairs and glute running and glute swimming, you should be glute ellipticaling. So every time you push down on that elliptical pedal, that side, just like with walking, the glute should tighten up. And then as you push down the other side, the glute should tighten up on the left side. Same thing with cycling. It's the same movement applied to different exercises, the same muscle contraction, I should say, applied to different exercises. If you can effectively do that and set the goal of 8 out of 10 steps or cycles, however you want to call it on an elliptical. If you're at 80% or better with using your glutes, then that's good. You should generally see that it doesn't hurt your knee and that it's helping your hips as well, but it's overall beneficial for you because it's the way we're designed to move biomechanically. Hope that answered your question there, Dr. Lyons. Thanks for asking. We got 2 similar questions coming up next. We have Lorna White says, how do you know if you have a muscle imbalance? Good. And then Lovely Jubbly says, how do you fix the muscle imbalance? I love it. So the number one way, in my opinion, to know that you have a muscle imbalance is if you have knee arthritis. The only situation where I've seen somebody develop knee arthritis and it wasn't clearly due to a muscle imbalance, I say clearly because I think there was still a role, is if you had a traumatic injury where you broke a part of the bone that makes up the joint. So like I did have a patient one time who crushed her leg in a car accident and broke the top part of this bone, had to have surgery to pin it together, and it didn't heal 100%. And there was changes within the joint. So after time, you're going to develop, there's a high potential you could develop arthritis in that way. But if you didn't have any traumatic injury to the actual joint, because I wouldn't be too bothered if you broke the bone down here or up here. You could recover from that just fine. But an actual change to the shape of the joint on the inside, it's kind of out of your control to recover from that. But if you have arthritis without a traumatic injury to your joint, you have a knee imbalance. You have a muscle imbalance. Your glutes are probably too weak. You could check that by seeing if your glutes fire correctly. And then you could check your foot muscles and your abs as well. Go through phase 1 of our program. You'll learn a lot, and you'll be able to have a lot more definitiveness on whether or not you have an imbalance. But probably a 99% chance you have an imbalance. And then the other part is, how do you fix the muscle imbalance? Great question as well from Lovely Jubbly. You need to strengthen the weaker muscles. So in the case of knee arthritis, we have over-dominant quads on the front of the thigh, the muscles that connect to your kneecap. And then you have weak glutes on the back. Can I show it on the side here? Might be a better view. So the muscle imbalance is these muscles on the front of the thigh are too over-dominant and strong. And so they're compressing everything at the knee joint here. And usually these muscles get over-dominant and they compensate because this muscle back here, the glutes, they're weak. They're not being used. They don't have good control. And so the muscles on the front of even the front of the hip and the front of the thigh, they will just compensate. Your body is so smart. It's so intelligently designed that if it figures out how to get things done. If you need to walk from here to there, if you don't have a muscle working for you, it just says, well, it's all right. We'll just divert things to another place and make it work for today. And if that becomes the normal, that you're always making it work with your quads, that's how you develop that imbalance. And so the way to fix it is to stop and think about using the right muscles. And so it depends on where you're at here, Lovely Jubbly, but you might need to start with just activating the glute muscles. Very often, that's where we're starting people out in phase 1. They don't even have glute activation, and that's causing some of these other symptoms as well. And then we need to make your glutes better and better as you go along, and as a result, the symptoms often get better and better as well. Now, there's other imbalances too, like in the feet and the abs, but the glutes are the biggest imbalance to begin to correct. Go check out our free phase 1. You'll learn a lot there. Cindy says, every question and all your information is very helpful. For me, it is the hips, but I learn more and more on each live. Fantastic. The best takeaway, Cindy, and I think that's why you're here, is this same muscle imbalance that I talk about that affects knee osteoarthritis. That's the root problem of knee arthritis. The quads being too strong, the hip flexors also get too strong, the glutes get too weak, too underused. It's the same imbalance that causes hip osteoarthritis. So if you've got a hip problem, it causes hip labrum tears, hip bursitis, hip tendonitis. It is the root problem to a lot of joint issues in the hip and in the knee, even in the low back. I see it as like overeating, being overweight is the root problem to diabetes, hypertension, like high blood pressure, cholesterol problems, strokes, heart attacks, all those extreme situations where you begin to take medications, They could be oftentimes helped if you eat right. But we focus on the short-term treatments that don't really solve the root problem. It's the same thing with arthritis. We focus on, let's get the knee replacement, let's try this injection, let's try this medication. When we need to focus on the muscle imbalance, it's just not mainstream yet to do that. So glad that you're making the connections here, Cindy. I hope I can help you continue to fix your hips. Mike Music says, is there specific massage techniques from a therapist that will help heal the knee arthritis pain? I am doing all of your recommended exercises now. I'm in phase 2 and 3 exercises. Great, Mike. That's awesome. This is a tough one to answer as far as specific massage techniques, because I would only worry about pursuing specific massage techniques from a therapist if you lack motion. If your knee doesn't bend all the way or straighten all the way compared to your healthy knee, or if it's both knees that are affected, compared to when it was healthy, what I would want you to pursue with a therapist if you have a limitation in motion is to try to get more motion. And so the specific techniques, most therapists kind of know them. All therapists are aware of them. I'll put it to you that way. All physical therapists are aware of something called joint mobilizations. In the knees, one of the most commonly mobilized joint in physical therapy, doing a mobilization for flexion or bending and doing a mobilization for extension is very well known in the physical therapy space. What varies a lot from therapist to therapist is the quality of which they can do the joint mobilizations. In other words, everybody got exposed to it in school, and you might run into therapists that are like, well, I haven't done one in a while, years probably. And then you have other therapists that are like, I do them all the time, like every day. I do them, half my patients or more than half my patients get knee mobilization. So you have to kind of figure out who's better at it in the clinic that you're at, or maybe amongst the clinics that are available to you to see what you can benefit from the most. So you might need to try different therapists for that. Or hopefully you hit success with one. At the end of the day, if you get more motion when you had less motion, I'd call that a success. That'd be the only technique I'd look for them to help you out with to heal arthritis. After that, it's all muscle imbalance. Like 97% fixing the muscle imbalance is going to heal the knee arthritis. Mewtwo said, I have pronounced synovitis. Is that dangerous? Oh, I don't know. I'd have to. So synovitis means swelling of the synovium, of the joint capsule, of the ligaments around the joint. Now, here's the thing. Okay, he's also asking to see if it's dangerous to exercise with a swollen knee. I guess another comment here. Oh, there it is. Can we do exercises with a swollen knee? The short answer is you shouldn't do any exercise, whether your knee is swollen or not, if it makes your knee hurt more. That being said, to dissect it a bit, there's potentially some exercises that you can do with the swollen knee that don't hurt you and actually probably improve your knee. A great one I'll show you is tailgate swings. This is magic for swollen knees, for most swollen knees, not all, but a lot of synovitis, swelling in the joint, can improve from doing this kind of exercise. Now, this is short term. This is going to solve the whole knee arthritis problem or the whole synovitis problem. For those of you guys wondering what synovitis is, it's just swelling in the joint capsule swelling. Doctors like to pull out these big terms, which are accurate medically speaking. It's for medical terms, but for the public, it's just swelling in your joint. I would not, though, exercise if it hurts you, because you're going to irritate it more. The pain is your body telling you this is hurting me, obviously, but don't push through it. Only push through things if it's related to fatigue, like you're getting tired, but not pain. You have to begin to get that distinguishing sensation as well. Hope that helps you, Mewtwo. All right, Tammy says, what is knee crepitus? My knee sometimes buzz or vibration going through it. I've not had knee arthritis, but I have severe feet and ankle arthritis. I suddenly get buzzing in my knee. Crepitus is noises and vibrations coming from your knee associated with motion. So like when you bend your knee, it creaks or it cracks. It has like crunchy sounds in it when you bend it. You might get it in your ankles or toes as well. Other joints in your shoulders, your neck, your spine can get it as well. It's just noises. There isn't always pain associated with it though. I have crepitus all the time. I pop so much in my joints. People can probably hear me coming from far away because every time I take a step, if I haven't been walking around, I creak and crack. And it's okay as long as it's not hurting you. Now you can have crepitus that hurts, and that to me is just a sign that whatever's making noise is irritated. The surfaces within the joint are irritated when they go over each other. The crepitus usually happens because there's irregular surfaces are not smooth anymore. So it's bumpy in there, in other words, and it's making noises. It's going through the bumps, but it can be fine if it's not hurting. Now, to answer your question about the buzz vibration, that could be a nerve sensation. It could be a crepitus sensation as well. But just remember what I said. If you have the noise or the vibrations with movement, it's more likely crepitus. If you're just at rest, it could potentially be a nerve problem. I forgot that there was a nerve condition. Oh, it's been a long time since I've looked at it, but everybody has this, the sensation where you feel like something's crawling on your skin, and then you look and there's nothing there. It's not a dangerous thing for the most part, but it's a sensation that we all kind of get, and it's just your nerves acting up for some reason. So it might be that you're getting some version of that. Hope that helps you, Tammy. Caroline Shipsy, UK says, as always, Dr. David, thank you so much. You keep me motivated and hopeful. I can avoid a knee replacement. Thank you. Thank you. Awesome, Caroline. I hope that you get rid of your knee pain completely and get back to being active, walking as much as you like, getting down, up and down, going up and down stairs, in and out of chairs, dancing, doing everything that you want to do. Thanks for joining us here, Caroline. T. Moore says, do stronger glutes help with sciatica pain? Yes, 1,000%. When I have somebody coming in to see me with blatant sciatica, one of the first things we're working on is glutes. Abs, lower abdominal specifically, and then glutes are the close second. We work on both of those things. Super important for you to get better glute strength. Absolutely, yes. Monica Starr says, are you able to touch on pes anserine bursitis? They can't tell me the source of my pain, if it's arthritis or pes anserine. Yeah, I'll show you here in a second, but just to be clear, it's often that both of those problems are related to the same root problem. So let me show you what I mean. If we're talking about pes anserine bursitis, let me draw. That's a good drawing point. If we're talking about pes anserine bursitis, the pes anserine is about this area right here, and it's the attachment point of a hamstring muscle and an adductor or a groin muscle. And so it's a little bit below the knee joint. The knee joint, just so you can see, it's hard to know exactly where it is on yourself, but there's a line where it's the top of the shin bone and the bottom of the thigh bone where they meet together. That would be the knee joint line. And so if you have osteoarthritis, very often it hurts right on the joint line. But if you have pes anserine bursitis, it can hurt on the joint line and the pes anserine area. But here's the other thing too, is you've got nerves all over your body, and there's a major nerve that comes through here. It comes off your femoral nerve, branches this way, and then there's one that goes this way right along the joint line through that pes anserine space, and the nerve actually keeps going. There's a branch that keeps going down your inner leg, but this nerve is called the saphenous nerve down here, and there's a recurring nerve that runs this way. It's a nerve that goes over the front of the knee, and so all things can get hurt. And what happens in the medical field often is the doctors kind of list all these different diagnoses, different conditions. Well, maybe you have pes anserine bursitis. It could be arthritis. Maybe you had a meniscus tear because the meniscus is in the joint too. Or maybe you have a nerve problem. They list all these things and they leave people scratching their head and trying to decide what treatment to do, because the diagnosis you get should dictate the treatment that you pursue. And the thought is, if you have pes anserine bursitis, you do this treatment. And if you have osteoarthritis in your knee, you do this treatment. And it's different than Pez-Anserine bursitis treatment. And then if it's a meniscus tear, it's different than those other two. So it gets so confusing. But the beauty about the treatment approach that I'm talking about, which is rooted in the muscle imbalances, is that all these conditions that I just said, meniscus tear, Pez-Anserine bursitis, knee osteoarthritis, a saphenous nerve irritation, they're all happening as a result of the muscle imbalance. And the muscle imbalance, just to show you what I mean, is you see the drawing on my leg right there. If you put too much compression and or tension in the area, you're going to irritate all of it. It just might show up as swelling in the area, and so the doctor's thinking more Pez-Anserine bursitis. You might get an X-ray, and they see that you have signs of osteoarthritis in your knee, so then the doctor's going to bias your diagnosis more towards osteoarthritis. You might have some lingering pain down your leg or up your leg, and so they might think you have a nerve issue. Let's do a nerve conduction study test. Or you might do an MRI and see that you have a meniscus tear, and so they're thinking that that's the source of the problem. They're just going off these things. What they're missing completely is that there is a muscle imbalance, and that every time you go to walk, you're using these quads too much, or you go to sit down, you're doing this with your knees and over tensioning and getting these muscles stronger, and it's compressing the knee joint too much. We're missing the point. As a medical field, it is the muscle imbalance. And don't get caught up in splitting hairs too much on, well, is it Pez-Anserine? Is it this or is it that? Fix the muscle imbalance. You probably have weak glutes, weak foot muscles, weak lower abdominals, over-dominant quads. And if you start to correct those problems, you'll probably fix it up. Good question there, Monica. All right, we got time for one or two more questions here. We got Susie Schneider, who says, hamstrings cramp up when attempting a bridge. 72-year-old, deconditioned. I think this is the person that called us. This is the Susie that called us. BMI 36, sit to stand, also seems to hurt on the knees and not feeling glutes despite able to activate glutes when sitting or standing. Thanks for suggestions. So just to summarize that one, the cramping in the bridge is a sign that your glutes aren't working very well on a bridge. And so your hamstrings are saying, I'm trying, but I can't, and they cramp up. And then, you self-admittedly deconditioned, so you probably do have weak glutes. BMI 36, just over the cusp of being able to not have to worry about weight loss, but I think you should worry about weight loss. Sit to stand is difficult to get the glutes to activate, and it's going to hurt the knees because it requires more strength to move your knees from a bent position to a straight up position, a standing position. You need good glute strength to do that effectively. Otherwise, your body just figures out how to do it, and it says, let's ask the quads for help. Let's ask the TFL for help. Let's ask all these other muscles for help to just get up right now, or to do an exercise in other positions, but you're missing using the glutes because you don't have enough glute strength. But if you get the glute strength up, which is going to take you some time, you got to go through the phases of our program appropriately to make your way safely to the point where you're going to work on stairs in phase 3. Then you should be able to make more consistent progress, Susie. So hopefully that summary helped you out. We got Darlene asking, my right knee has arthritis. How do I get it calmed down while still working on my other knee from tibial plateau fracture surgery? Oh, I had the tibial plateau fracture. No fun, but you might still have an excellent outcome. You probably will. I've seen a lot of people with tibial plateau fractures do just fine. They just have less margin for muscle imbalances. You have to offload. That's a tough one. I mean, you might need to just prioritize being off your feet in general. So this might be a time of your life where you get help from loved ones around you. You get somebody to help you cook, help you grocery shop, help you do the chores, so that you can not irritate your painful knee, your right knee that has arthritis, and allow the left knee that has a tibial plateau fracture to heal fully. It might just be a couple of months. Depends on your specific situation, but eventually you need to get back up on your feet. It doesn't mean you just completely do bed rest. You can fire your glutes while you're lying down. You can keep them active. You can start to work on left versus right. You can do toe curls. You can sit on the edge of the bed and grip the ground with your toes. That's another version of toe curls. You might be able to stand. and still use your glutes in standing, there's a lot of things you can do. There's a ton. I would go through the free phase 1 for a program, for the knee arthritis recovery program, because it sounds like that's where you're at. And I would work on what you can based on your specific situation while you're in phase 1 of the knee arthritis recovery program. Hope that helps you out, Darlene. We got Forizat from Houston. I have a torn meniscus. This changed my life. I tore my meniscus last August. I have followed what you recommended. Is the vibrating plate good to rebuild the meniscus? Good question. Okay, so hopefully you mean it's changed your life for the positive? I don't know. You have a frowny face on there. Hopefully you're going to get better if you're not better. But as far as the vibration plate, I personally have not seen tremendous improvements from using the vibration plate. There's just a handful of research studies out there that show that there could be some improvements. But if we're looking at it common sense wise, if you're standing on a plate that's causing vibration through your body, is it teaching you to move better? Probably not. Is it making your muscles stronger? Like, can you stand for longer, get up easier, pick up more weight in a certain exercise? Very rare. It doesn't translate because you're just standing on a vibration plate. You might have your knees bent, you might be in a certain position, but it's just vibrating and it's making your nose tickle. I've tried these before. I don't think that it's a huge carryover into practical functional activities that are really going to offload your meniscus to let it heal and get you to where you're very active again, not even worrying about the meniscus tear, and definitely preventing knee arthritis and having a knee replacement later on. So my best advice here is go through our knee meniscus recovery program. We have a program called the Knee Meniscus Recovery Program. We built it because there's a lot of people that were on their way to knee arthritis but didn't quite have knee arthritis yet, but they had a meniscus tear. And having a meniscus tear is one of the big factors that ends up leading people to getting knee arthritis eventually. And it's the same spectrum. It's the same muscle imbalance that affects a meniscus tear. So my best advice is go through that program. We have a ton of videos on YouTube as well that are specifically for meniscus tears, and start to get your glutes stronger, start to get your feet stronger, abs as well, and you're probably going to feel a lot better in your knee joints. I wouldn't focus on the vibration plate though. I'm not saying don't use it at all. You might use it, but don't use it in place of fixing the muscle imbalance. You still have to do that. All right, guys, we're wrapping up. Thank you all so much for joining me here on this Tuesday to talk about the top questions we get from everyone that's trying to heal their knee arthritis. I am looking forward to joining you guys real soon again. You'll have a wonderful week. Bye.